My name is George Nashak, and I'm the President and CEO of Care for the Homeless. I want to welcome you to today's seminar, Meeting the Need, Dismantling Barriers to Behavioral Health Access for People Experiencing Homelessness in New York City. We want to thank MasterCard for sponsoring this important discussion this morning. A key part of Care for the Homeless's mission is to prompt discussions about important policy issues that impact the individuals we serve. We achieve that by hosting several public discourses throughout the year, and this seminar is an essential part of that effort. Convening advocates, service providers, academics, elected officials, and people with lived experience of homelessness gives us a platform to discuss opportunities to not only respond more effectively to episodes of homelessness, but also to contribute to the crafting of long-term solutions. We have assembled an excellent panel of experts to engage in that effort today. We know that untreated behavioral health issues, often resulting from lack of access to comprehensive health services, contribute to and perpetuate homelessness. The impetus for today's topic comes from a need to evaluate both the availability and efficacy of behavioral health services for people experiencing homelessness in New York City. Behavioral health policy and program cross multiple service sectors in our city. Today, we want to identify policy recommendations to improve access and address the systemic barriers to care, and to do so without further stigmatizing individuals with behavioral health needs. Thank you for joining us this morning. We hope that you will find this to be a rich discussion. It is now my pleasure to introduce our moderator for today's panel, CFH's own Executive Director of Healthcare, Michelle Everett-Oxley.
Thank you so much, George. I truly appreciate this honor and privilege to be your moderator today for such a very important topic. And we are, as George indicated, we have a wonderful list of panelists that will be able to provide us the insight and perspective as to helping us to discern how best to dismantle these barriers to mental health. And in order for us to just get started, we want to be able to introduce these panels to you today. So first we have Dr. Rebecca Capasso, who is the Assistant Director of Inpatient and Psychiatric Services at Bellevue Hospital Center. Thank you, Doctor, for joining us. And Dr. Tony Carino, who is the Director of Psychiatry at Janian Medical Care. And our very own Edna Cavalli, who is our psychiatric mental health nurse practitioner at Care for the Homeless. And happy Nurses Week to you, Edna. And Dennis, who is our poet and consumer advocate. Dennis, welcome. And our very own Simone Thompson, who is the director of our shelter operations at Care for the Homeless. So we want to just dive right in. In order for us to really understand, to help to frame our discussion today, we want to just offer a quick synopsis as to what you think are the most prominent issues regarding access to behavioral health services for people experiencing homelessness in New York City. You have the opportunity to expand on these discussions as we continue to dialogue. So what do you think are the most prominent issues regarding access to behavioral health services in New York City? Dennis, could you give us your own experience in accessing behavioral health services, and what worked for you and what didn't work for you?
For me, I think the main thing would be what's in the very title, the access. So one of the most memorable moments that I had was when help came directly into the shelter. So, you know, it's hard to sometimes go out, even though you know that there are services available, and it makes a fundamental difference when those services are brought directly to you. So that would be my first thing. And then the second would be communication. Just, I know sometimes when you're dealing with providers, the language can be very clinical. And I think sometimes you have to speak the people's language. So those would be my main two things that I'd say should be addressed to overcome some of these barriers.
Thank you so much, Dennis, for sharing that perspective. And for you, Dr. Carino, I know that this year you co-authored a report with the Bronx Work Organization, working to improve the care coordination for homeless individuals with severe mental illness in New York. Can you walk us through what you found to be some of the more prominent barriers to effective care coordination for our community hospitals, community-based providers and hospitals, and what were some of those solutions in that report?
Yeah, happy to, Michelle. Thank you. So a paper with BronxWorks and UCS co-signed onto the paper, which highlighted some specific structural barriers, specifically between hospitals and community-based providers. What we found was that when the coordination communication was high between hospital ERs, inpatient teams, and the outpatient practitioners and teams, outcomes were positive. We saw a series of challenges that were connected to a reduction in inpatient psychiatric beds. Actually, in New York City, in 2006, there were about 2,100 inpatient psychiatric beds. And as of February of this year, that number was down to about 1,100. So we've had this 34% drop in inpatient beds in New York City, coupled with the challenges with the pandemic due to disruption. And so what we found was an increase in boarding in people with mental health crisis being held in the ERs, emergency rooms. We found challenges with coordination where some patients would stay for a while in the ER and be sent out to outside the city, Westchester County, Long Island, where the coordination was extraordinarily challenging. And we also saw sort of increased in challenges in communications with the inpatient teams. During this period of time, we also found that there were some long wait periods for people to access assertive community treatment, ACT, or intensive mobile treatment teams, which have evidence base for people experiencing homelessness. Not only that, the process for AOT, assisted outpatient treatment, which for a very small number of individuals can really help and support people in reducing homelessness, reducing risk of victimization, reducing risk of suicide attempts. That process was primarily pushed through only through the hospitals, so that people couldn't access those supports based on their community providers. And so people were only able to access AOT through hospital-based services, which was a major bottleneck. So some of these findings led to specific solutions. First off, coordination is key. And so when the psychiatric emergency rooms, CPEPs, inpatient teams can coordinate with the outpatient psychiatric providers, the outcomes are going to be effective. There's often times that someone might be in a mental health crisis and might need extended observation in the ER, or just access to medications, a long-acting injectable, for example, before they leave. And so communication is important. Some of the outpatient street psychiatrists and outpatient community psychiatrists had access to the electronic health record in the county and city hospitals, which was effective. And so further coordination such as that can be helpful. And then there's a series of structural recommendations that are very much key. So first off, we see a drop in homelessness following historical New York City and New York State, New York collaborative agreements to build supportive housing. Another collaboration would increase the scale of supportive housing that's needed to support folks with severe mental illness. Second thing that could help is an increase in extended care units. These are units for inpatient care for people with complexity and homelessness, where the length of stay isn't just a few days, but can last up to weeks to months and involve coordination with community providers. We've seen success with that at Bellevue. Another recommendation is an increase in assertive community treatment and IMT teams, so that there aren't long wait lists for people to access really important flexible supports, and an increase in access to the New York City support and connection centers. These are a series of potential crisis diversion beds that would divert people from psychiatric emergency room and criminal justice system. And right now, the access is not that high, and there are two, but it would need to be ramped up to scale. Finally, having psychiatric practitioners, nurse practitioners, psychiatrists out embedded in the community is a highly effective way to connect with people and provide services. The relationship is key, and people need to trust and develop trust over time to accept services. And so embedding psychiatrists, psychiatric nurse practitioners in the community where people experiencing homelessness are and go is essential to developing those relationships that are needed for treatment. So those were some of the key findings that we found.
Thank you so much, Tony. Really appreciate that insight. And what are some of the biggest challenges to you and your colleagues that you experience when you're trying to coordinate care for the unstably housed folks while caring for those in the hospital and once they're discharged? That question is directed to you, Dr. Capasso.
Thank you again for having me here. I just wanted to say it's really a pleasure to be a part of this panel. I think some of the biggest challenges that we have coming from a hospital, part of the public safety net hospital system called H&H, Health and Hospital Corps, and I work at Bellevue, is the almost constant request for quote, a higher level of care. I can guarantee if I get on the phone with an outpatient provider, a community provider, someone in the person's life outside of the hospital, the number one thing they're going to ask me for is a higher level of care. And I think just as Dr. Carino was just saying, the problem is the access to that higher level of care is difficult because there are long wait lists for ACT teams. AOT can be put in from the community, but it's difficult. You need to be able to go to court and testify, and that can be a barrier to a community provider who's not used to doing that kind of thing. There's only one extended care unit, and it's quite restrictive to get to qualify for that. State hospital beds are very small and limited, also, as he said. And so while you can put in all the applications, it's called a SPOA, a single point of access to access any of these. I see some questions about ACT teams versus IMT teams and what that means. The main problem is those higher levels of care either aren't available, they're not scaled up to the need we have in the community right now, or it's that there's such a long wait to be able to access those excellent services.
And dovetailing into that notion of not enough beds available, the bottleneck of having those patients appropriately placed as it relates to a higher level of care. And then tell me a little bit about the link between homelessness, mental illness, and incarceration, which we all know is very well documented. So can you speak to that from your perspective?
Good morning, everyone. Thank you for having me. And yes, the link between homelessness, mental illness, and incarceration. And I must give you a little about my background. Before I came to CFH, I used to work at Rikers. So there I met a lot of inmates with mental disorders. And while I worked there, I realized a lot of them got arrested for petty crime because when they were acting bizarre on the street, and they called 911, and who showed up as first responders, police officers, which some of the police officers are not equipped to deal with people with mental illness. And they get arrested, and they bring them to Rikers Island. Unfortunately, they have mental illness, but what they bring them for, it's petty crimes. So while they're at Rikers, they get into more trouble, and which translate into a longer sentence. And while there, they may not receive mental health until it reaches a crisis level. So in order to prevent this from happening, we need to educate the public also about how to differentiate the symptoms of mental illness versus criminal action, and also to educate the police officers on how to handle people with mental disorders, and and society to be educated about the stigma that associated with mental illness, and that stigma still prevents certain individuals from seeking help that they deserve, because they feel vulnerable if they ever go to look for mental health care.
So would you say that some of those barriers and hesitancies that they're expressing in seeking mental health services even before they get to Rikers is prevalent? Yes?
Yes, definitely. And some of the barriers like trust, they have difficulty trusting, difficulty building a relationship with providers. And some of them do not have, they rather, instead of seeking for mental care, they rather medicate themselves with either drugs or alcohol. And they also feel like society is being very judgmental toward people with mental disorders, and also communication. Some of them do not have funds if there's no way of contacting them even for a follow-up appointment. And no money, they also have no money. And the cultural gap, if there's a cultural and racially underrepresentation, they don't see too many people that look like them, so that will facilitate them to open up to the providers. So that's one issue they usually bring to me. And also a lot of them don't come from stable housing. So if you don't have stable housing, mental health is the last thing that's in your mind.
Thank you, Edna. Thank you. Simone, thanks for joining us. And we would definitely love to know, as it relates to your position as a director of shelter services for care for the homeless, what are some of the more pronounced issues that you experience when trying to refer any residents that are experiencing some psychiatric episodes and do require a higher level of care, whether it to be hospitalization and any other treatment facilities?
Some of the tougher issues that we deal with are, I mean, there are many. I would say the ones that I'm going to talk about today are twofold. So we're seeing more and more elderly coming into our facility who probably under regular circumstances might be eligible for nursing home care, but many of the nursing home don't want to work with, or not, I shouldn't say don't want to, they're not equipped and able to work with people who have significant mental health issues. So they're equipped for the elderly who are frail, who may need nursing care, but the psychiatric care that many of my residents who are elderly require, it's just not readily available in the nursing home. The other issue that I think is a big problem for us are clients who, I know deinstitutionalization has its ups, but we do see a lot of clients who are not able to make decisions that are good in terms of, I'm not talking about someone who just chooses not to take their meds, but they're doing okay. We're talking about the very, very sick who may take off to the streets when EMS shows up, who is able to present fairly well for a moment in time when EMS shows up, but who is very, very ill and probably require long-term hospitalization. So I'd say those are some of the most challenging. I would say right now we have a pretty significant portion of our clients who are the over 60 who are just very, very mentally unstable. And again, the other thing that we see a lot of here, not only are they mentally unstable, but they're not healthy. They have significant health challenges, and combined with their mental health is just not, we're not able to get them into the long-term care facility that they may need.
So yeah, when we talk about barriers in terms of, deinstitutionalization, decompensation, denial, danger, and all of the above, it feels as though those barriers are very much problematic in the way that we serve our patients in our various facilities and throughout the community. If we can speak a little bit to what the impact, and Simone, I guess we'll throw this one either to you or to Edna in regard to the impact that also may have on the current residents that are at the shelter and the staff in trying to find appropriate services to assist that person that may not be nursing home eligible and or could be decompensating due to their untreated mental health conditions.
If they are decompensated because of their mental health condition, we usually refer them out either to Bellevue or wherever they might have a bed available for further psychiatric evaluation, and we hold their bed at the shelter, and for when they come back, they usually go to the same bed, and after they come back, they will see me for another evaluation to determine their baseline.
Yeah, so Dennis, in terms of what is missing when we speak about the increasing access to behavioral health care and for unstably housed patients, do you have any suggestions in terms of facilitating access for people that otherwise may not be able to interact with behavioral health services prior?
Yeah, I can piggyback on what Dr. Edna spoke about, because he raised a good point about the lack of trust. Dealing with providers for years in different capacities. So sometimes you might have to take an indirect approach, right? Because I know, it's funny, but I would always joke about free refreshments. I mean, I don't know if we can still do free refreshments we're still in this kind of pandemic thing. But even something like that, you get them with something else so that they don't necessarily get intimidated by, the behavioral, mental health services, because that stuff, like even what Dr. Edna said, some of that stuff has a stigma to it, so sometimes if it could be like a movie or whatever, but just things that they will find interesting, and you hook them with that, and then you have these services available. And, and eventually, if they're showing up for whatever it is that they're interested in, and maybe it could be some sort of art or things like that, eventually they will probably just gravitate to these services that are available. So I think that's one thing that could be added to the mix that would make people who need these services actually take advantage of them.
Thank you. Yeah, so we're confident that in meeting our patients where they're at, is a great way to build trust and confidence in our ability to be able to serve our patients effectively. And so can we talk about the effects of the stigma that has increasingly prevented our patients, particularly, to get care? And how can we combat that stigma in our communities as we work to provide services to them?
I mean, I would say one thing that I see with many of our clients, especially the ones who are not necessarily compliant in taking care of their mental health, they have this fear of, I would say, being locked away, as opposed to seeing that maybe that 30 days will get you the freedom to get housing, get you the freedom to get long-term care. I think many of them have a fear of losing their freedom. So, like really working with those clients to help them to understand that it's temporary. And, we're seeing that more and more of those clients are spending years in the shelter system. And in their moments of clarity, they're asking about housing in their moments of clarity, and helping them to understand the tie between getting mental health care and getting permanent and long-term housing. I think sometimes that's the challenge. And when you have Care for the Homeless, we have the health center on site. So working the case management in the shelter, working with the healthcare sometimes helps them to trust in both ends a little bit more. So the case manager can walk over and sit with them with the provider. So it's care coordination with them at the center of making the decision, like, hey, you know, if you sit through the evaluation, the case manager will be able to process a housing application for you. So I think sometimes helping them to alleviate the fears that they have about their future.
Beautiful. And so do we think that by providing some of these resources that may be missing, that within the care coordination model in our communities, would we be able, is there enough, firstly, to be able to help with this issue of the lack of beds and the like? Do we think that we can talk a little bit about what creative solutions there could be in trying to treat our patients in the community with care coordination at the forefront?
I definitely think that there are solutions, and there is a way of providing that kind of full wraparound service to our clients. But I do want to go back and talk about something we've touched on, which is the stigma, right? And recognize that our clients are, the majority of folks in homeless shelters and mental health shelters are people of color. And so we know that there are social determinants of health that are playing into this. We know that there is structural racism that is playing into this. We've talked a little bit about that trust, right? To be able to build that trust. I've been reading all the comments. You know, we have shelter systems where there's DHS guards, which is very intimidating for a lot of people. There's a lot of rules that people need to follow. And we've talked about that stigma, right? That people who are experiencing mental illness are thought of as dangerous, right? And so to be able to provide care for them and resources to them, I think one thing, we can talk about scaling up and practical solutions, but I think we'll always have to acknowledge and as best we can address that underlying stigma, that we may not want to provide more financial resources for folks if we fear them, if we think they're different or they're dangerous, which from the literature we know is not true. People who are experiencing mental illnesses are not more dangerous than others. They're in fact more likely to be victims and be victimized. So I just wanted to acknowledge that while I think resources should go into this, we also want to make it a very patient-centered experience where, again, maybe there's not security that they have to go through so hard, or maybe there is some refreshments that makes it feel more welcoming, and maybe, you know, we can address some of those things, because a lot of what I hear of people who have rejected shelter, or they'll even come in with supportive housing and say, I want to leave, and I'd say, why? You have the supportive housing, this is it. And they'll say, I don't feel like I'm treated very well. I don't feel like I'm getting what I need. So I think that part of engaging people is really key.
Thank you so much.
I want to agree with that. I want to agree with that because part of what we see, and I saw something pop up, hospitality is universal. I don't know who wrote that, but you know, I think that's part of the problem. I think sometimes people think because someone might not be well or stable that they're incapable of understanding how they're being treated. And people know how they're being treated, even if they're not well in the moment. And so that's one of the things I emphasize the most as I hire staff. Even if someone is not well, they are the customer, and good customer service is important. And clients who have mental health disorders oftentimes are treated as if they're not visible in terms of their humanity, and reminding all of us that that is like key. They are like the patient, the client, the customer, and they should always be treated as such.
And also, because of the stigma, some of them refuse to accept their disorders, that their own diagnosis. So I feel like education is important. When they come to see me, I usually try to teach them like your brain is like it's an organ, just like people have heart problems. and you have your brain is not working properly, that's when you come and see us like providers. Educate them to make them able to accept their diagnosis, and that way not to turn on to drugs or alcohol to medicate themselves.
Well said. Yeah, and I think, in speaking to Dr. Capasso, when she talked about the cultural competency and maybe even the lack thereof, in terms of how we are addressing patients that may present in a way that is different or unique, really exploring what other sort of modalities that there may be. When you hear someone who says that they have, or they're hearing voices, and the recommendation for them may be that, they want a room to pray, or that they would prefer, to sit in quiet and meditate, or perhaps even do yoga in the park. How creative can we be as a community of professionals in trying to explore what other health modalities that may be non-traditional in order to address some of our concerns when presented in a situation with patients? Anyone can try to collectively address that.
I would like to address that. As the poet that's been, invited to the panel, I'd be remiss if I did not talk about voice, the importance of voice, listening, letting someone know that they have voice, because once you have voice and you can speak and people are listening, it gives you agency. You feel like you have some power. And, as I was listening to everyone talk, I actually just now had a flashback of something that I repressed because it was such a painful memory. And this is when I was trying to access mental health services. When I was still in the shelter, I just was having a bad day. I was just stressed out. I mean, I was tired of all of the flatulence and all of the yelling and all of this stuff. And I told the people on duty that I want to go to Metropolitan Hospital. I want to just speak to somebody, because I guess that's another issue too. Some places don't have 24-hour, mental health services. And when you have an issue, it doesn't always fall between 9 and 5. It may be 1 o'clock in the morning. So that's definitely another thing to look into. But this was in the wee hours, and I go there and I explained to them, I was very articulate with them. I said, look, I'm not going to hurt myself, but I'm having those ideas in my mind. And I made sure to explain to this nurse that. So she tells me to come with her to go to this room. And when I see the room and I see that people have to be buzzed in and out, I immediately became wary, because I was like, wait a minute, this don't seem right. I'm just here to talk. I'm not here for all of that. And I asked the lady, and I specifically asked her, I said, because she wants me to go in there, I said, if I go in there, am I going to be able to come out? Oh, sure. So I trust her. And I go into the room, which, now in hindsight, it was the psychiatric room. I hear the door closes, I hear it lock, and then a guy comes up to me with a big paper bag, and he tells me to take my clothes off. And I'm in a state of shock, and I'm like, no, why am I taking my clothes off? Long story short, he calls in another big guy. I'm a big guy myself, but he calls in 2 bigger guys, and these guys took me in the room. I can't even use the language that they used to me, but they forcibly took my clothes off, strapped me to a bed. Then the doctor came in, gave me a shot, that put me out. But it was a very scary experience, simply because they had the power. I had no voice. And it even occurred to me that if I don't appease them, I could get lost here. no, you know, so that was a very scary experience, but it comes to mind because here it was that I tried to access services and I had this horrible experience. So I can imagine that you have other people who've had these kind of experiences, and that is definitely a barrier. So I would just sum it all up by saying, I guess accountability is another factor. You know, it's okay, you know, mistakes are sometimes made, but do we take accountability and talk about that openly? Because at least if you're talking openly to people like, look, I know these things are where mistakes were made, but let's talk about it and then figure out solutions.
Thank you so much, Dennis, for sharing that.
Thank you. And it's about respect, having your voice heard. And again, it's one of the reasons that we want a hospitalization, let's say, to be the last resort, right? Because we want people to have that freedom and autonomy. Coming into a hospital, for the most part, necessitates losing a lot of freedoms. And the other thing I wanted to say, that the word that I would use hearing your story, which you say so eloquently, is trauma.
Yeah.
And I think we can acknowledge that becoming homeless is traumatic. There's so much loss, and being in a shelter is traumatic. Being hospitalized is traumatic. And we want to reduce the experience of trauma in people who've already had so much trauma. And we need to be able to work together to have voices be heard and to protect people going through a very vulnerable, scary time.
Dennis, thanks for sharing that, and sorry that you went through that, and that experience, you're right, is all too common. And for people experiencing homelessness, there isn't choice in self-direction in all of the systems and supports that are designed to support them. And I think your idea about voice is so important. One of the things that we've seen is with our consumer advisory board members, people with lived experience of homelessness and mental health challenges, that going out into the shelters, food pantries, supportive housing can be extraordinarily helpful, just to sort of overcome some of the barriers and fear that people have, and just say, hey, I was here, you know, where you were. And we found that sort of embedding and learning from people with lived experience is so important for us to be flexible and hear people. And so I think, you know, having that voice and elevating that voice is really essential, and something that should be done on the ground with clinicians, with programs, and sort of with any structures that we're building.
But also it seems like, Mr. Dennis, that his trauma was treated as if he was incapable of good decision making. And I think that sometimes is part of the problem. We have people who are significantly mentally ill, people who are traumatized because they walk through our doors seeking help. And someone who's traumatized is not incapable of making good decisions for themselves. And it sounds like that's how he was treated.
Yeah, and I think that, you know, in seeking help doesn't make you helpless. And in that instance, it felt and seemed and was portrayed as someone who was seeking help in all the right places, but unfortunately was mistreated and misdirected. And unfortunately, that has been the story of many that have tried to access behavioral health. And so we are seeing the stigma almost giving life to the fact that it becomes a situation of feeling hopeless in that instance. You know, we would be remiss if we didn't discuss some of the substance use components that can impact and will impact from a MICA perspective, mentally ill and chemically addicted patients. And so we know that the leading cause of death for those experiencing homelessness in New York are drug related. So what do we think in terms of the impact of recovery resources are available? Can anyone can take that question? And I'm pretty confident that we can have a robust discussion around that matter by itself or in its entirety.
So I think a lot of the deaths are unfortunately due to the opiate overdoses, and fentanyl is driving this increase in overdoses. And we've seen that escalate during the pandemic, but it was escalating before. And people with mental health challenges and homelessness are at increased risk of that. I think there are really important treatments out there, such as Suboxone, which has been associated with decreased risk of overdose, longer lifespan, and actually decrease in suicide for people with mental health conditions at risk for suicide. And those can be accessed. The challenge, I think, is that all of this and access to care really rides on the relationship that we've been talking about. That for somebody that's experiencing homelessness, who's going through withdrawal, that there's a lot of trust that has to be involved in accessing supports. People have to sort of trust, ensure that that support team is going to be there. They can get on that medication with minimal withdrawal symptoms. And so getting out there and connecting with folks is really, really important, and providing a lot of self-directed choice and harm reduction support to build on that relationship can really help, because we can offer Suboxone, methadone, all of these agents. And it takes an element of trust and a lot of and building on that relationship to help folks. We've also seen real benefits with engaging people in conversation with people with lived experience as well, and peers, and to sort of engage folks and talk about harm reduction approaches, and providing supports out there in the community can be a really effective way of engaging people.
Thank you, Dr. Carino. Thank you. Anyone else want to talk about other resources that may be available in their own settings? Yes. Yes.
30th grade, each participant get a knock-in kit in case they see somebody having overdose symptoms, so they can save a life. So we also run classes on how to use the kit. So that has been very effective.
Wonderful.
Not available at Bellevue, but I wanted to highlight the Safe Injection site that has recently opened up in New York City. Again, on that spectrum of people who are trying to reduce the harm and may not be ready for Suboxone is great, Narcan is great, but just also a safe and destigmatized place where they can come and maybe use safe needles, clean needles, have a needle exchange. So that's a great program as well.
Thank you. So as we move towards the concept of deinstitutionalization, what we know is to be a community-based service model. And we know that this is to treat individuals and behavioral needs, but we understand that the community is frightened due to some of the more exposed media perspective that has been pronounced in our news daily about those that are perceived to be homeless onto the streets and causing some concerns for the community. So we want to talk about what have we seen in the shelter and in the correctional systems that have become de facto mental health facilities. Anyone's open to take that.
Well, I've thankfully I've been out of the shelter system for a couple of years now, but in my memory, as far as it becoming like I mean, you could even say it's become, and maybe Dr. Edna can affirm this. It's also become like a de facto Rikers certain places, at least where I was at on Wards Island. I mean, the heavy presence of DHS, who really, and you know, I have nothing, you know, against the police, but I mean, again, when you talk about people of color and our interactions that we have historically had with the police, and you know, the DHS, it's pretty much the same difference sometimes. So I definitely think that is a problem. That's a problem actually to accessing services, because sometimes you don't want to leave because you know about the headache to get back in. You know, the place where I was at, you had to go through a metal detector. They searched all through your stuff, you know, lift up your socks. And, you know, the word respect came up. This being homeless is a very dehumanizing experience. And I know there were stretches of time where I could definitely have used services because I was depressed. I just wanted to lay in the bed. But having to go out, deal with the DHS and the headache of going out and transportation, you know, getting off Wards Island, having to ride the M35 bus. Yeah, so that's my my comment.
Thank you. And I think it is a sentiment of many folks that even as we talk about the removal of encampments around the city and how that impact enforcing folks into a situation whereby they are losing control to some extent by, you know, monitoring the fact that they can't come and go as they please, and that they are being, you know, Dennis, as you indicated, you know, dehumanized because of the fact that they are at the mercy of the facility that tells them that they can't, they have to be in by a certain time and the like. And so as much as we may agree to disagree around that whole notion, but I do think it is the sentiment of many of folks that are living on the street and have chosen not to return into the shelter life. So
Michelle, just to add, that's why the safe haven model is such an important model. Yeah. Because, you know, as you know, Care for the Homeless just opened a safe haven and there is no curfew. So it's an 80-bed facility, and the gentlemen who have been coming in are the ones that are being, some of them that are being disrupted in the various encampment. And, you know, at first they're hesitant to come in, but what we've noticed, we've only been open a month, but what we've noticed, the freedom and knowing they could come and go have been helping us to build rapport with them, that our goal is really long-term to help them to hopefully get permanent or supportive housing. And again, many of them in the beginning are not trusting and very hesitant to stay. But as they've been with us a month, they've seen that if they leave for a couple of days, they come back, we're letting them back in, and we're, you know, picking up where we left off. So I think that the safe haven model, which has expanded a bit, is very useful for the chronic street homeless who don't like the confinements of some of the shelter rules.
Beautiful. Thank you, Simone. Thank you for that. So what do we think happens to our vision of the community-based treatment model to include, you know, again, if this was a blank canvas, what would that potentially look like in order to address a lot of the barriers that we have discussed over the last 45 minutes? What would that look like?
I think we're gonna, it's very complicated. I think it's gonna have to be a multi-pronged approach. There's no one solution. I think my concern has always been deinstitutionalization and these actions on folks who happen to be living outside in the street or in the subway is usually happening before the community resources are really built up and put in place. So they'll say, we want to build more safe havens, as Ms. Thompson was saying, and that's great. But that only opened a month ago. So my suggestion is that we need to ramp up the resources that we want for people before we close hospitals, state hospital beds, before we have to convert psychiatric beds to COVID beds, before that last one would have been hard to do, but before we take people off the street, we should really have the thing built for them to go to. One experience I had during COVID is at that time I was working for another organization, and we had really good success with hoteling. So that housing first model where you had a private room, and our incidents of aggression and violence and fighting went way down. Our need to take people and refer them to the emergency room plummeted. We just had much less need, to access those services because they had a private room. It was calmer, quieter. They could sleep. People told me how much better they were sleeping. There was still rules and regulations, and it can still be traumatizing. I'm not trying to diminish that, but I think if we are talking about a housing first model, right, where the person has a safe, non-traumatic place to live, and then we have the resources available for their actual care, that higher level of care, then we can start to really respectfully give the people the resources, let them choose what they want, what works for them in their lifestyle, without needing to we move first, I think, to deinstitutionalize or to move encampments without having those resources kind of prepped and ready, which sets us up to feel like we're failing, even though everyone's working very hard.
Thank you. Proactive, right? Proactively anticipating the needs of our community and making sure that we do have I love the notion of the crisis respite beds. And I know that sometimes that's just a Band-Aid on a coma, right? Because we know that they're not enough crisis respite beds. But I mean, even to give that as another component of respite as we talk about mental illness and seeking out modalities in order to manage medication, in order to work with patients that may be just at that brink and need that opportunity to collect their thoughts and get away from the environment that potentially could have placed them in a situation that is precarious. So yeah, I think the proactive component is definitely something that we want to explore and to advocate as far as our politicians are concerned around that concept. So thank you. Anyone else want to take it from a blank canvas?
I think, I was watching the chat and the chat was going crazy and everyone was saying housing. And that's my language right there. Cause I'm gonna tell you, I got back at least 50% of my sanity once I got my housing, right? So, I understand that, it's a process and I love that safe haven and how even like, you can still give a little something, but it should always have that at the forefront, the housing, because the work that the panelists are doing, they're doing great work. But the truth is that, the shelter system is dangerous. And that's why so many people, it has to be dangerous because if it's a code blue and someone would rather risk hypothermia than go to a shelter, that tells you right there. And I know from personal experience, and I've seen others, there's some dangerous people in there, And so yeah, housing solves. It's a great panacea. It solves a lot of ills. The housing.
Thank you.
And just to piggyback off that, I think right now our services aren't really built around people and people's needs. And so having services actually designed around people is really essential, right? And so I think this, a lot of the rules and restrictions in a lot of our support structures don't fit the needs of folks that are in appropriate survival mode and want to be safe or have co-occurring complex disorders, right, and conditions. And so I do think that that sort of ramping up supportive housing and also adding in supports and treatments as accessible to people is really essential. People aren't necessarily experiencing homelessness going to follow up with traditional clinics. And so as we ramp up supportive housing, having flexible teams, I think building a system around this extreme flexibility has been helpful. I think that's why intensive mobile treatment teams has led to engagement for folks, just that it's extraordinarily flexible and teams and support teams can get out and connect with folks. And also sort of having an access to, as people have been saying, crisis stabilization. So they're not in institutions, criminal justice or the ERs unless they need to go to the ER and hospital. And so I think building up those supports is really important. And along the way, the supports really need to be empowering for people and emphasize choice and self-directedness.
Beautiful. Yeah, so we are coming to the point where we're going to actually look at some of the questions that are in the chat. We're looking at, okay, let's just see if we can maybe have a few more questions in the chat, and then we can direct some of those questions at the panelists. So I would say, yeah, there's a lot of questions here. Let's go with okay, hold on one sec. I think if we wanted to really further this discussion around resources, I think that would be an opportunity for us to really try to encapsulate all what we discussed today in a way that, again, will have folks walk away in knowing that there are resources that are available. I think that we didn't touch too much upon the concept of telehealth as well, for our patients to access our behavioral health components, mainly those that are connected with Care for the Homeless and many of the other FQHCs throughout the city, has been successful in providing this type of care. We understand that the barrier also can be a phone, right? I mean, as simple as a phone or even access to knowing how to navigate those telehealth appointments. And so we're really grateful that through the Department of Homeless Services, that many of our clinics do either have on-site provisions and or can access telehealth appointments virtually. So we're hopeful that that also is a barrier that we've had probably in the past, even prior to COVID, where access was so limited, and that appointments were so far out, and that culturally competent therapists were not really available to the extent that hopefully they are now. So we want to walk away from this symposium with the concept and the notion that resources are available. And so we want to start to take a look at how we can explain and put in the chat some of the things that we've done well. And let's highlight some of the success stories, as Dennis is definitely one of many that have been able to utilize the system in a way that ultimately has come out on the other side. And we hope and we are really confident that in continuing this dialogue, that we can continue to find many other success stories that speak to the great work that we're doing in terms of dismantling those barriers. So Natalie, I think we want to start with some of the questions in the chat as we're at that time. So potentially, I see a good one. Okay, well, there are many. So many are comments as well. So if we could, there's only space. Someone had asked a question about I think we talked about this in the earlier part, but never got to it. The actually description of what an ACT team would be able to help the patient that may be in a behavioral health challenge. Anyone would like to take that question?
So the question is, oh, go ahead.
What services are available through the ACT team in providing behavioral health services to our patients?
So I work on a homeless ACT team in the Bronx, the CUCS ACT team. So it's a multidisciplinary team, including psychiatrists, psychiatric nursing, case management, social services, and provides a sort of comprehensive approach around behavioral supports. So connecting with family and partners, getting out in the community and meeting people where they're at, and sort of coordinating with outside programs. It's 68 participants, and the staffing ratio is relatively high. It's really a shared caseload and really flexible model and approach. ACT is associated with decreased time in homelessness, decreased hospitalization, emergency room contacts, and decreased incarceration. ACT is really a way to sort of provide really high quality, comprehensive support for people that have complex needs and are utilizing emergency rooms and hospitals a little more frequently. How one accesses those is what Dr. Capasso was talking about through SPOA, an application, and can be an effective treatment approach.
May I add one piece, Dr. Carino? One of the really good and important part of an ACT team is whether the client, if they move from one shelter to the next, the ACT team could continue to coordinate and work with them so they don't lose that continuity of care when they are transient, whether it's through shelter or otherwise.
Great point. You know, Simone, we talked a little bit about the question or the concern that's growing with the amount of elderly patients that are aging in place, so to speak, in some of our shelters throughout the city. One of the concerns, obviously, is their safety, but also the increased need, be it, you know, in their assistance with ADL care or the like. We understand that with the homeless population that the life expectancy is still fairly low as it relates to the rest of the population, but it is increasing. I think if it would be important for us to dialogue just a little bit about what kind of resources would you like to see in the case of patients that are, again, not eligible from a PRI standpoint, getting into a nursing home or assisted living, but what services would you like to see in the shelter services that will enable us to safely support someone who is aging at a Susan's Place?
I would say, just like in the general population, the aging population have a need for psychiatric care. And if someone's mentally ill and have serious mental illness when they're 40 or 50, they're going to continue to have those needs at 67 and 80. So nursing homes that are developed, keeping in mind all the needs of our elderly, and not just our elderly who their bodies are failing them, they're frail. There's also the elderly who need help with their mental health disorders, and for them to be ruled out of those facilities because of their mental health need, it's a failure. So I'd like to see more facilities that ramp up psychiatric care to care for that portion of the aging population.
Awesome. Yeah, and I do think that your point well taken, 40 to 50, you know, untreated depression can and will lead to forms of dementia, which then deems them ineligible to care for themselves. as the dementia progressed. So yes, I do think, in terms of how we are looking to keep our patients safe, I think that's a really important component as they age.
And if I could just add to that, but both from my experience, there's also a nice comment in the chat, the skilled nursing care as well. So psychiatric care is key, but especially if we're talking about a dementia type process, what they might need is either skills training, home health attendants, and right now there's barriers that those folks can't go into a shelter. So even if someone has a home attendant, a home health aide, those folks aren't allowed to come into I've tried to get them assigned before, and they won't come to the shelter. And so I think that's a barrier that we could maybe think about advocating so that those people with their specialty and their training could come in and help us care for these folks who are aging in place at shelter.
Excellent. And as all of us know, the staffing concerns, as I heard about the skilled help and need in some of our nursing homes as well, one of the concerns has to be, or a barrier would be to find staff that is growing, educating in the field of behavioral health, particularly under a cultural competence banner. Can we talk a little bit about what barriers that may present as we continue this dialogue around staffing or lack thereof?
I think it's difficult to get adequate staffing, at least from my experience. And then it was difficult to train the staff. Yeah. So again, we would run up. My experience is my former career. We would run up against barriers. Again, there was that stigma that folks who were experiencing a mental health crisis or might be intoxicated were dangerous, and therefore let's call 911 and send them to the hospital. And a big thing that I like to advocate about is verbal de-escalation, right? Approaching someone with respect. Coming to them to say what's going on. Why are you upset right now? How can I help? And maybe introducing myself if they don't know who I am. Why is this lady coming to talk to me? And verbally being able to comfort, de-escalate, and calm people down will lead to a lot less problems. But that's an extensive training, right? That might need to happen. So first there's the struggle of hiring up staff. And then there's the amount of investment and education that sometimes our staff need in order to approach folks who are going through a crisis with that respect, that giving them their voice, all of those great destigmatizing, very humanizing things that we want them to be able to do.
Excellent. And in a way to incentivize them into the profession, right? So that in order for, how many of us, whether it be our entry level into the career, would prefer to be in a facility that, you didn't potentially have to lock doors or the like. And so what are some incentives that perhaps the profession can look at in order to attract the best and the brightest and the most compassionate, engaged, and invested professionals to work with our patients? I know it's a loaded question, but
I want to just jump in right before that, because that's not necessarily my area of expertise. But before you think about attracting new, I want to advocate for all of the panelists here. There are wonderful people, there are wonderful staff, there are wonderful directors, nurses, therapists that are doing great work. And I know none of you could admit it, but there are lots of headaches, unnecessary headaches, things that stop you, that take you away from doing the work. And a lot of times people who don't have, they're not the ones with boots on the ground, so to speak. They're not the ones who are getting their hands dirty, but yet, they're, telling, I want to appreciate the staff that we do have, the ones that are doing good work. I want to show more appreciation for them, because sometimes there is a lot of turnover, and that's a problem. You have good people and you lose them, and it's like we have to keep going back to start all over again. So let's just appreciate the great workers that we have and take care of them and show them that they're appreciated. In the words of Tupac, you are appreciated.
Dennis, I'd like to say the same thing. I think our staff are pretty incredible. I think once in a while, you may have a negative situation and you overlook the 99% of the time that they're doing incredible work. Like I've seen a couple of the chats where certain people who are not able to take care of their ADLs, they're not allowed in shelter. Well, I have news for you. I've seen staff help someone get in the shower because they were not able to do it themselves. So lots of incredible work is happening, and I think our staff are absolute heroes in terms of the work they do day in and day out. And I think oftentimes, again, once in a while, the negative things outshine the positive, but more, I would say 99% of the time, the work that's happening is incredibly positive, and our staff are doing a really good job in a system where when you go to work in a nursing home, you know it's the elderly. Go to work in a prison, you know they're there for committing crimes. When you come to work in shelter, you're working with everybody who walks in the door. And it's oftentimes, you don't know what to expect on the next shift, but yet they come, they bring it all through COVID. They are not a group that got applauded and got clapped for, but they were here every day. For the entire time of COVID, I would say, other than when someone tested COVID positive, all of the staff showed up every day and gave it their all when, a lot of people were at home. So our staff are pretty incredible.
I agree. Totally. And I think that the objective of what we try to discuss and to present about what are some of the more prominent gaps in behavioral health access and how we are addressing those shortcomings in our current system, and asking ourselves, what investments and policy changes do we need to achieve these goals, and how can they best be coordinated with the models that we presently have? I hope that, our goal is to offer, and I know that our goal is to offer a systems level view of issues that continue to have this kind of dialogue that will talk about what needs are being met. I do want us to take an opportunity to just highlight, even if we did it by virtue of the chat. I mean, you can participate in this way as well. If you can just put in a 1 to 2 words narrative as to things that we think that we've done well. I think that would also, again, be a ray of hope in what we know we can do better. So we can start this exercise, again, 1 or 2 words, put into the chat what you think from your organizational standpoint, or from your lived experience, or from who you are in terms of your management style, and what you've seen has been successful in your endeavors in working with bringing down those barriers. 1 or 2 words. And on my go, let's do it. Love it. Better shelters, advocacy and compassion, showing empathy, testimony and advocacy, listening, safe harbor, listening to our clients. Keep going, guys, keep going. More training. Awesome. Empathy and training. Respect and teaching. Gaining trust, dignity and respect, showing trauma-informed care, being respectful and kind. Respect, quality of life, better referrals, building rapport, reasonable accommodations, connecting and building trust, communication, destigmatizing folks, compassion, respect, active listening, listening and not being judged, better wages, following up, don't be afraid. Yeah, okay, so we're going on. And I do think that in doing this exercise, it gives us the opportunity again to focus and reflect on the great, good, and awesome work that we're doing in the field. We know that we haven't yet accomplished everything that we hope to do, but we are confident that with a collaborative team approach in working and breaking down those silos, in understanding and respecting folks for who they are. There's an African proverb that goes, I see you. And so it's so very important that in spite of anyone's situation or circumstances, is that the lens that we see people through gives us the opportunity to respect them in a way that we hope that if we were in that situation, that we too can be respected. And so we're really grateful for the opportunity to dialogue in this fashion, in this symposium. And I'd just like to give the panelists some final thoughts about what you think maybe we didn't bring up in our discussion, a ray of hope to those that are listening, for those that have tuned in and taken their morning today to discuss some of these very, very important critical issues. And I'll just throw it out there. Whoever wants to go first, you can just take yourself off of mute. And let's end on a very positive note. I think, Edna, you were first.
Yes, I like Dennis's story, and he gives me a lot of encouragement to keep going to work and do what I do. And I would like to see more successful stories like Dennis in the future.
Thank you.
And I would like to, thank organizations like Care for the Homeless who let me know that my story has value. That means so much. That I have a certificate right here. I could just, since it's right here, I might as well just show it to you. Can you see it?
Yes.
Yeah. So I mean, it may seem like just a piece of paper, but that means so much that there's someone who feels that, hey, you're a success. And you're worthy to be celebrated.
Thank
That
you
means
so
a lot.
much. Thank you.
Well, and I just have to say thanks again. It's an honor to be here amongst all of you. And I love showing up every day and collaborating with folks to figure out how are we gonna tackle these big problems. So thank you for all the work that you all do and the energy you bring every single day.
Thank you.
I just want to echo how valuable and meaningful the work is that you all do. I've just had so many experiences where somebody that was seen as in a space where they couldn't get support, or people were experiencing them as there's not a lot of hope here. The interventions that social service workers, clinicians have made, even when people can't hear it, years later they'll speak to it. And it makes a big difference. So just want to thank everyone that works in this space, that supports people experiencing homelessness. And even if we don't see the benefits immediately, people are listening and people are impacted. So thank you.
Thank you.
I agree with what's been said thus far. And Dennis, I love having you on this panel, so it could remind us that when we do our work well, we can have an outcome of someone like you who will come to the table and remind us every day that we need to bring our best so we could help move more people into having a wall to hang their certificate. So thank you for coming, because it helps me to push forward and do better, so I could see more Dennises out there telling their story. Thank you.
Closing, I just want to, firstly, I want to thank the panelists. They have been an amazing group of professionals that have shared their challenges, their ups and their downs, and their success stories. And Dennis, again, just having the opportunity to meet you and to dialogue with you, I know that I'm a better person for it. And I thank you for sharing being as vulnerable as you have been and sharing your story. Also thank MasterCard for sponsoring this amazing event. And also to remind you that there is a survey that you will be able to participate. It's our goal also to be able to collaborate all of the suggestions and the comments and resources that will be helpful in our opportunity to reach out to you as you do your work, to be able to post that resource guide for you onto our website. So please stay tuned for that information. I want to just again thank you for spending this amazing opportunity in sharing your stories, your successes, and your challenges. So thank you, thank you, thank you.